Hello.
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 Taylor and Bill loving the sun there. It's nice, nice.
Gotta embrace it while we can, you know?
Absolutely. Yes.
Yes.
Hello everyone.
Hey, Ramita.
How are you doing, Dr. Jonathan?
I'm doing well. Yeah. Yeah.
Nice.
Well, before we start, I had a question. If we have to miss didactics one of the weeks, is there anything just to let you know?
Yeah, you don't have to let me know. After today's lecture, I will update the YouTube channel, and then I'll send you all a link so that you can watch it whenever you want. But it's fine. You don't need to tell me you're going to be gone or anything like that. It's totally fine.
Thanks.
Yeah. Getting my slides up here. Okay, y'all see my big old weed plant there? Yeah, all right. The marijuana leaf. Cool. So it looks like we'll go ahead and get started, actually. Before we get started, I wanted to make sure that you all had a chance to ask questions about anything reviewed last week. I know that it was a lot of information to cover. So if you had questions about that, please feel free to shoot with those questions before we get started today. We're going to talk about cannabis. And hopefully be able to review some of the basics and increase some information about kind of new information. I don't have wonderful treatment medications to present to you, but we'll talk about what exists and what we can do for folks today. But were there any questions about alcohol from last week?
Have you ever used oxazepam or ever seen anyone else use it in a withdrawal setting?
Yeah, no, I haven't, and that's mostly because I've been in the University of Washington system since my career started. I do know that it is used. There's not as much data as there is with Librium or diazepam. So, the thing about alcohol literature that's interesting, particularly withdrawal management, is that um, there's the data that we have is fairly limited actually prospectively. So there's actually a whole lot we don't have evidence about, and we do more based on clinical experience and local culture and algorithms. Um, is there anyone who trained on the East Coast, Northeast in particular? Okay. So, like for instance, if you look at the algorithms that they use at Brigham and in Harvard, they are incredibly aggressive when it comes to actually alcohol um, uh, withdrawal, and they'll give much higher doses of benzodiazepines and phenobarbital. Based on how much someone is drinking. And, there's not really other places that do that, but it's very interesting because it is Harvard. So it has been adopted at certain other places. But when you actually look at the research, there's not a ton to actually support the idea of using higher doses of benzodiazepines or phenobarbital than is described in the literature or other places that use these medications. So yeah, I think um, there's a lot more about algorithmic management within a system and knowing what the algorithm is within your system and being able to utilize the medicines. I think the other thing too is that it's really important that nursing staff be comfortable with the medications, and if you throw in something new that they don't know anything about, it's nerve wracking. Even if you are, doing dosage equivalents of oxazepam to Librium, for instance. Um, the other thing too is just the oxazepam, temazepam, and Ativan or lorazepam are all theoretically medications that could be used for as needed treatment. Lorazepam works so well and his onset of action is pretty quick that that's kind of what we do. But other questions? All right, let's talk about cannabis. So we're going to talk a little bit about the mechanisms of action, treatment, and then kind of the epidemiology and the changing landscape of cannabis. Um, so, who is from Washington State? Is anybody from a state that did not have legalized cannabis before coming to the state this year? So, Lena, where were you?
Wisconsin?
Okay. Um, cool. Uh, yeah. It's very interesting because the I think the states that do not have legalized cannabis, you're just going to see from an epidemiologic standpoint just much less use, and I think the sort of general gestalt of, oh, cannabis is ubiquitous and legalizing won't make a huge difference is kind of silly. The more available a substance is that actually interacts with the dopamine reward pathway, the more people you will see who use. And actually, use patterns are very interesting too, in that they're really tracking along with alcohol in terms of what you'll find is that a subset of the population buys the most percentage of the substance itself. So, which makes sense. Over time, um, you'll see how this actually has influenced the potency of cannabis and the potential pitfalls of doing that. So I'm going to try to see if this will allow me to open it. Ooh. And I'm going to stop screen sharing, and I'm going to share this other thing. So can you see the slide? It's a or at the website. It's this cartoon looking thing.
Yes.
Can you hear it?
No.
No. Okay, makes sense. So I'll talk you through it, but this is an interesting uh, uh, website because it actually was developed at the University of Utah through a grant from SAMHSA, and it's super helpful as the basic sort of understanding of substances of abuse, but also really helpful for patients. That's kind of cool. So we'll take first off, and, all of these mice are using different substances. Can anybody find the mouse who's using or LSD? This guy, right? He's having a little visual tracer here. Back here is cocaine, paranoid, methamphetamine, angry and paranoid, alcohol here, ecstasy party back here, opioid on the couch. This is so. Uh, Cannabis actually influences its effect, or THC, in fact, influences its effect on CB1 receptor. The CB1 receptor is this receptor. Uh, so within any strain of cannabis, there can be hundreds of different cannabinoids. We know a lot of information about only a few of these cannabinoids, one of which is THC. And THC tends to be um, uh, uh, the substance that is highest in terms of potency of the different cannabinoids that you'll get in any strain of cannabis. It's the psychoactive one and the one that makes people feel euphoric and high. So um, what happens is that normally the CB1 receptor is actually occupied by what is called internal cannabinoids. Uh, and molecule, what happens is that the inhibitory neurotransmitter is then actually turned off and allows dopamine to come into the circuit here. If you actually stimulate THC, it's much more potent than anandamide, and so it will produce a lot more dopamine, uh, the neurosynaptic cleft, and lead to feelings of intoxication. Um, it hijacks the dopamine reward pathway just like any other substance of abuse. Um, and so when I actually started in fellowship, patients had this uh, misconception that we back on slides. You can see them. Okay. Patients had this misconception that uh, cannabis and or THC was not uh, addictive physiologically, that it was only psychologically addictive. And we know that that is totally false. And actually, cannabis is quite addictive, particularly with higher potency versions. So, us in the so THC is sort of the primary uh, cannabinoid that we talk about that causes that increase in dopamine, euphoria, anxiety, etc. But the other one is cannabidiol, and so this is CBD. And CBD actually works differently in that there's some antagonism at the CB1 receptor when it's activated by THC. So there's some thought that actually CBD can help reduce or quell the psychoactive effects of THC. And CBD actually in itself, we'll talk about at the end, if you can get pure CBD, actually has antipsychotic and anti-anxiety effects. So really works very differently than THC. There is some partial agonist activity on D2 receptors, and then also agonist activity at serotonergic receptors. So there's two sort of mechanisms for the potential of why they may help with anxiety. So I can't really stress this slide enough because um, uh, you know historically, people talk about different strains of cannabis, sativa being kind of the psychoactive, and then indica being kind of the chill version. If you go to a head shop in Seattle, or a THC dispensary, I should say, or a cannabis dispensary, they will tell you all sorts of things about different strains of sativa and indica and high potency THC versus CBD. And this is super confusing to patients. And the truth of the matter is, there's really, I want you to think of mostly what we know from evidence is THC with high content versus uh, um, cannabis that has low THC content, or high CBD content versus the THC itself. And instead of calling it sativa or indica, when you do buy this in a dispensary, to actually just look at the percentage of THC versus CBD. And that is much more important than whatever strain is being called. Questions about that? Does that make sense? Okay. So acute symptoms, so THC, positive symptoms, THC, anxiety, paranoia, euphoria. People can have this distortion in time and this feeling of novelty. This is the first time I've done this thing that is so creative and wonderful and this great idea. And then when it can go too far, people do have the potential for psychotic thinking, disorganization, hallucinations. And then the negative effects really are sort of the amotivation, social withdrawal, the memory impairment, and kind of being stuck on the couch, if you will. So this just shows, and this is actually an older study from 2012. So this is probably even more prevalent now, and that is that 95% of patients who actually we were using daily marijuana and trying to quit had some symptom of cannabis withdrawal. Most commonly, you get cravings, anxiety, and sleep disruption. I'm sure people have heard the narrative, I am not addicted to this, I just can't sleep if I don't use, right? So that is that uh, 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 withdrawal syndrome that is sometimes under recognized. So medications to treat cannabis use disorder and cannabis withdrawal. So there's not really great medications for this. We'll start on the left here, which is the acute phase when somebody's stopping abruptly. What can we do to help them with craving, sleep disturbances, appetite, anxiety, mood, GI symptoms, etc.? And I'll review this, but basically what we have is gabapentin, uh, uh, mirtazapine, Seroquel, dronabinol, nabilone, and then oxytocin and N-acetylcysteine. N-acetylcysteine is an interesting one because it's mostly been studied in children, but it's a fairly low barrier medication because it's really just a supplement. There's also pretty good information that there are psychotherapies that are useful for patients who are trying to stop using or trying to help improve their return to use. So CBT for cannabis, uh, 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 motivational enhancement for cannabis, and those are the main two. Contingency management has been shown to improve, but not actually utilized very much because it's expensive and it's really reserved mostly for methamphetamine and stimulants, given the paucity of treatments for that and the severity of negative sequelae from using cannabis versus using methamphetamine. So these are the medications that actually have some level of evidence. So zolpidem can be used for acute withdrawal in terms of treating insomnia. Not my favorite medication to put people on long term. People will actually develop tolerance to this. And when the package says don't give more than 10 doses in a month, that's real. Patients tend to actually take this medication frequently, and then it loses its efficacy. But that can be used in an acute setting. Mirtazapine and or Seroquel actually do have some evidence as well, and can really help people who are experiencing both insomnia and problems with nausea and or lack of appetite, which can occur when people are abruptly stopping cannabis. Um, the other things that can be used and actually have been effective is synthetic cannabinoids like nabilone, which is an oral medication. It can be useful when patients have a lot of cravings to use, but also nausea. This is a difficult one because at the VA, you can't actually give it for patients with cannabis withdrawal. You can use it for people with cancer, but this is absolutely something that you can do in the community. And then gabapentin, which actually I think is probably the most encouraging for both withdrawal management and cravings. And again, not directly influencing the dopamine receptors, but instead GABA, and likely helping with some of the anxiety associated. Naltrexone does have some evidence for reductions in use, and it does need to be taken on a daily basis. But none of these medications are, magic bullets like we have with buprenorphine and methadone for opioid use disorder. As I said, there's psychosocial treatments that have evidence for cannabis use disorder, which is the motivational enhancement, cognitive behavioral therapy, and contingency management. Um, who has seen hyperemesis syndrome associated with cannabis? Yeah. What does it look like, and how have you treated it?
Looks like frequent showers. So much showers, so many showers that they're just
I
overflowing the
can't
inpatient.
hear you.
Oh, wow,
You're
really?
not on mute though.
Huh, weird.
Can people hear him?
Bill, I can hear you.
Oh, okay. No, go ahead. That was an error on my end.
Yes, yes, this is like intractable vomiting. It's typically like I see people that are in the shower frequently over and over every 15 minutes, flooding the inpatient unit, and can last for like days at a time, and they're just really miserable. Things that I have seen, Haldol, I think, is one of the primary things that I've seen people use. Baclofen, let's see, just all the like Zofran and oh my gosh, all the different like anti-nauseas. And then just lots of conservative support. And we try to use like capsaicin cream on their belly, but nobody ever tolerates that.
Yeah, so it is funny because no one ever tolerates that, is exactly right. Can you see the slides again, by the way? What the? My computer just totally freaked out. I'll be back with you here in a second, sorry. All right, back on track. So The way this is diagnosed is the same as hyperemesis gravidarum, which is using the Rome criteria. And the idea is basically that people should have some set of symptoms consistently for 3 months with an onset of 6 months at least prior. The episodes should last, as you said, Bill, days, less than a week usually. And people do respond to medications, primarily benzodiazepines, Haldol, and or I'll show you the other evidence-based medicines, but capsaicin cream has been one of those that has been shown in the literature, but I have not had people tolerate it either. Has anybody seen capsaicin work? That says that's a no. Okay. So this can occur, clinically, you'll see these patients actually present. They'll tell you, I needed to escalate my use of cannabis so that I'm not nauseous. And then at some point, it'll turn on them, and actually, people can have these episodes that are elicited by using cannabis, and it's very quick. It'll happen, within a few minutes, and then last days, and and they shouldn't have any other episodes of other vomiting symptoms or GI issues. And like you said, Bill, you'll see these patients, taking super hot showers to try to help with this. The other thing, I think that's important to recognize with these patients is that the likelihood of this happening in people who have other GI disturbances is higher. So you see a lot of folks who have gastroparesis or some other IBS or other GI dysfunction that can actually put them at higher risk. The other thing too is higher potency THC tends to be a higher risk factor for development of this. So these are not patients who dabble in smoking once or twice every few weeks. These are heavy cannabis users who are using high potency THC. So as we said, so benzodiazepines are great. Benzos can help with anxiety, help with nausea. Volume repletion, totally undervalued. So you definitely want to get these people hydrated, because a lot of times they've vomited themselves into fluid deficit. And then weight-based Haldol dosing, as Bill had mentioned, is actually a one-time dose and can be really useful. Ondansetron is kind of depending on the situation, potentially helpful or not. And then capsaicin cream, which I, again, have not really ever found terribly useful for patients. Any questions about hyperemesis syndrome? Start with fluid, give benzos, and then if you need to, IV Haldol. All right.
I think the
Yeah.
thing I was always so striking to me is some of these they try to manage it at home for several days, and by the time they come in, these people, I've seen people with just rip roaring AKIs. I mean, like,
Yeah.
it's pretty like wow. And so it is not for the weak. It really it's amazing how much impact it can have on people. But
Yeah, electrolyte disturbances too, right? I mean, so really bad acute kidney injury, and then hypokalemia and pretty bad derangements in their sodium levels too. Yeah, it's not terribly common, with higher potency THC being more available. I suspect we'll see a little bit more of it, and I've certainly seen more of it over the course of years. I'd never seen hyperemesis associated with cannabis before about 5 or 6 years ago, and actually, I'll show you on some epidemiologic information about our potency in Washington State that tracks pretty well, because we've got much higher potency cannabis, really than anywhere in the world. So, hooray, Washington. All right.
I just wanted to, oh, sorry,
No, go
Jonathan.
ahead. No, go for
Yeah,
it.
I just wanted to share, this was like 3 or 4 years ago. I was working in urgent care. A guy came in and, worked him up, and, I was pretty sure it was cannabis hyperemesis, and gave him some fluids, sent him home with some Zofran, told him to quit, and he said that he really wanted to, followed up in like 2 weeks, and he was like, he had stopped using weed because of that. And he was like, wow, I feel so much like different already. And it's just a really interesting case, and like kind of an aha moment in this guy. Yeah,
Yeah.
so just interesting.
Yeah, I think it's a very high motivator for people who are really who have these bad symptoms. I mean, it can be really debilitating. I mean, obviously requiring hospitalization at times, and the and just the opposite, like great when people are highly motivated and it changes, but also shows you sort of how addictive cannabis can be, because you see people come back in who know that this is coming and it can happen and it's awful, and they're like, I shouldn't have done that, I don't know why I keep doing this. And it's a testament to how potentially addictive cannabis can be. um, uh, so um, we're going to move into some other psychiatric manifestations of cannabis. And I think, when you look at the overall sort of gestalt of cannabis use disorder and associated problems with cannabis, um, it's really there are certain patients who are at higher risk for problems associated with cannabis, and vulnerable brains that do very poorly when they're exposed to cannabis. And one of those is cannabis associated with psychosis. So this was a study in healthy controls, actually, looking at what is called the PANS, or a screening that we do for patients who have psychosis, in terms of like how bad is your psychosis. And even normal controls have some transient level of psychotic symptoms, be it paranoia, delusions, frank hallucinations, and those tend to actually um, last only a couple hours. And this and the x-axis is minutes in time. Uh, and so people can have transient experiences like this, but they usually go away. Unfortunately, there are a subset of folks who can actually have higher risk for development of schizophrenia or psychotic disorders associated with cannabis use. So, this was the first and largest study looking at associations of cannabis and psychosis. So, it was a Swedish male study. There were 50,000 individuals that were followed between the ages of 15 and 25. And so what they did was they said, if you are between the ages of 15 and 18, have you used cannabis more than 50 times? And if you'd used cannabis more than 50 times, they called those people high utilizers of cannabis, or heavy cannabis users. And in that group, they had actually a 6 times more likely hood of developing schizophrenia, or being diagnosed with schizophrenia by the age of 25. And subsequent to this, there's been several other studies showing actually that cannabis is highly associated with psychosis. And there really hasn't been a study to say that this is clearly causative, but the association is pretty pronounced here, and tracks pretty well, even across different studies that are not just men in Northern European countries. So from this study, they've had a number of different subsequent trials to sort of try to delineate what other things are going on. And the first thing that they looked at actually was this enzyme called COMT, which is an enzyme that degrades dopamine, epinephrine, and norepinephrine. And this is what they found when they looked at these various genotypes of people. So um, again, on the bottom here, this is no adolescent cannabis use, meaning less than 50 times, or adolescent cannabis use or heavy cannabis use more than 50 times between the ages of 15 and 18. And so A up at the top left is those who had actually been diagnosed with schizophreniform disorder, which is the precursor to schizophrenia, that first 6-month period of time where you meet criteria for schizophrenia, but you haven't had the symptoms yet for 6 months. And you can see the homozygotes for this VAL gene, when people use cannabis, puts them at incredibly high risk comparatively to those who are homozygote for MET-MET or heterozygote for VAL-MET. The self-reported hallucinations, similarly high if they use cannabis. Percent of reporting hallucinatory experiences, similar. Those who present with delusional symptoms, and then those who have informants saying that the person has some sort of psychotic syndrome. And so, so there's sort of the hypothesis that there's genetic predispositions, and then also uh, the predisposition of how much you use and how potent that use is. So the other subsequent study here that I think is an important thing to see is what happens when patients do have psychosis associated with cannabis, and is there a difference between patients who do have psychosis who used cannabis or didn't use cannabis? And so this was 357 cases reviewed from inpatient and follow-up care. So these are people who are admitted for psychosis. And what you can see here is that if you use cannabis, that you have almost twice as many hospital days on your first admission. The number of readmissions is almost threefold that of those who don't use cannabis, and the total number of hospital days is almost 3 times as much in this window of time looking at these patients as well. So if you do have a patient who has psychosis or schizophrenia, you can actually very confidently tell them that cannabis use will result in longer hospitalizations and more hospitalizations. And if you've taken care of anybody with schizophrenia, in the hospital, most do not want to be in the hospital. So you can use this as a sort of motivating piece of information for folks who have psychosis. This study actually shows how frequency and potency of cannabis may also actually be linked to the development of psychosis. So if you look here, they did this study in 3 separate cities in Europe. So London, Amsterdam, and Paris. And what they did was they asked patients who were admitted to the hospital with psychosis what they were smoking. And because all of these cities have legalized cannabis, they could go back to the dispensary and see what was the percentage of THC within the strain that they were actually using. So if you see here in London, the daily use of more than 10% THC was much, much higher in terms of the odds ratio of developing psychosis and being admitted for psychosis related to cannabis than if you were using a less potent THC. And then the daily use is much more associated than weekly use or rare use. So that tracks along with Amsterdam and then also Paris. Any hypotheses as to why these cities have such different odds ratios in development of psychosis?
Cannabis is legal versus not legal?
So they're legal in all three of these places. Good guess.
Is it just like culture? Like Amsterdam's kind of associated with like, you know, uh, weed use and stuff, cannabis.
Yeah, so no one knows, this is just a theory, but they comment on this in the paper, and that is that the limitation here is that we're talking about THC over 10%. So if your THC was 11%, or 96%, that was in the same category. Has anybody been to Amsterdam? So um, Amsterdam has very potent cannabis compared to some of these other cities. And uh, when I went to Amsterdam last, the percentage of THC in most of these head shops or dispensaries was on the order of 15, 20%. In Washington state now, if you go to any dispensary, it is inordinately hard to find cannabis that is below 10% THC. Most products you get are going to be much higher than that in the flower formulation. And in most settings, the heavy user of cannabis is actually going to be using even higher potency than that. In the liquid formulations and vape pens, for instance, or the oral medication or oral formulations, gummies, chocolate, etc. Most of these things are above 70%, and you'll see anything all the way up to mid 90% pure THC, and people using that level of THC is very, very different than smoking cannabis that is a flower formulation at 3%. And so I think this is a ADAI update of what actually is happening in terms of concentrates and how much is actually being sold that is um, uh, uh, based on the percentage of market share for extracts versus um, uh, flour. So the concentrates actually sell a lot better. They are cheaper. They actually tend to be more efficient for people. So if you get a gram of flour and smoke that, your ability to actually extract all of that THC into your system is much less than if you're using a vape pen that is highly concentrated, or that you're ingesting a gummy that has 10 milligrams of pure THC. You'll see here actually flour with less than 10% THC is not available anymore. This is the latest update that we have because this is from ADAI, but you'll look and see this is from 2016. So if you go to a dispensary, you just can't find this stuff. So we are dealing with high potency THC in Washington state as a rule. And the cannabis trials up until now have all been really limited by the fact that we are comparing apples and oranges here, right? Can you imagine a study that said all we looked at was how much someone drank, not the content of the or percentage of alcohol, but just the volume? Very different if somebody's drinking Bud Light versus slamming Everclear, right? It's a very similar situation with cannabis. And so we've got to be much more specific in terms of use and pattern of use and content of the use, um, uh, and not just how much do you smoke. Has anybody had success asking questions about content of THC or THC to CBD ratio? And do people do that? So I would highly suggest when you do ask about cannabis to ask about, as you would any other substance, what do you use? And then how much have you used? Is it escalating? That's part of the criteria, right? Is you use more and more to get the same effect, and that's tolerance, right? And then also whether or not they're looking at the labels and know what they're actually ingesting. And for the most part, patients will know that what they're after, but they may well not understand exactly what they're getting. And the bud dealers, or bud, David, what was it called? Bud tender. That's right. Bud tenders. The bud tenders at these dispensaries will make up all sorts of shit, and really give bad information to patients. Um, so before we move on, any questions? We'll start talking about some cases and other things here. Okay. Some of you want to read this for me? This is a real case. Fascinating patient. If you come to Seattle, or if you come to the VA in Seattle, you may see this man. He comes in and out.
I can read it. 41-year-old man presented to the ED with severe disorganization and agitation after moving from Florida to Washington in order to practice my spirituality through cannabis. Patient's notable history: several hospitalizations for psychosis in the past, mostly in his mid to late 20s, early 30s. Able to maintain 5 years outside the hospital in housing and with no medications prior to the move. Studied biochemistry at FAU, completed 3 years.
So he smoked cannabis since his teen years and says it's always helped with his anxiety, and he found it helpful with spiritual connections. And he says hospitalizations in his 20s was a conspiracy by the Baker Act mandate. So Baker Act is the law in Florida for civil commitment for people who have mental health disorders that place them or others at risk. So I wrote this down because it was such a wild, amazing, wild statement. This is what he said. I'm seeking the position of Grand Poobah Institute Systems Biology, Neurocircuitry, Plasma, Chiral Center Justification, adjuster from an insane communist China leader. So he was monotone in his speech. His affect was flat. He had odd facial expressions and stared at the floor and wall. He postured in his seat, moving almost constantly, and then sometimes he raised his arms at his sides like a scarecrow. And when I asked him questions, he would repeat the last 2 or 3 words prior to attempting to answer. He walked on his tiptoes when he was leaving the room and repeated the phrase Institute of Systems Biology many times out of context in the conversation. Anybody know what the diagnosis for this is? Psychiatrists don't say anything. So this guy smoked himself catatonic. So he actually had a Bush Francis at 23. We put him on lorazepam, and it actually helped tremendously. He became more fluid. He was able to speak in full sentences. And what you'll see is that people who do have psychosis or a history of psychosis, people who have genetic predisposition for bipolar disorder or manic episodes, actually can have cannabis-induced syndromes, either a psychotic decompensation, a manic episode, or psychosis specifically related to cannabis use. And so it's important to recognize this guy in particular was a heavy cannabis smoker, but he was using in Florida where it was not legal, and he came here and had a 10x potency cannabis that he started smoking, and had never had a history of catatonia in the past. He's come in a few times since this initial hospitalization. But how would you counsel this person? So this guy was dead set. Even after we'd treated his psychosis, we did put him on an antipsychotic. Um, how would you counsel this person on um, how to use or what to use? Is there anything um, uh, uh, who anything that works and or you could suggest to someone like this? Are there any harm reduction measures?
Maybe if he's going to use cannabis, to use a product that is a lot less potent.
I love it. So we don't know for sure, but it makes very good sense to do to recommend low potency THC and anything that you can get that has higher CBD levels than THC levels. And I'll show you here in a second um, about why that is. Also, I missed the uh, uh, chat here about the uh, nausea associated with cannabis use, and it's totally accurate. Or like patients will tell you like, no, 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 I started smoking cannabis and it helped my nausea so much. And it's just really that like switch in understanding. Like, yes, I totally acknowledge that that was the case when you started using, and it is now turned on you because of this new syndrome that is called hyperemesis syndrome. Okay, so other psychiatric comorbidities. So cannabis and depression and suicide. So there's a meta-analysis and systematic review that was done in 2019. It looked at many different articles. 35 were selected as longitudinal and prospective, almost 24,000 or more than 23,000 patients. And it looked at cannabis in adolescents younger than 18, and then looked at development of depression into young adulthood. They did adjust for baseline depression, anxiety, and suicidality in these studies. And what they found was that um, uh, there was not a tremendous overlap of anxiety in young adulthood, which actually surprised me. I thought anxiety would be um, uh, more correlated with cannabis users, but actually depression was more associated with cannabis use. One thing I will say here, though, and this is the downside of looking at meta-analyses, is that you can see there's really only one study here that was really, really strong and pure, and the others are actually a lot less robust. But when you pool the data, it can actually pull it one direction. With that said, more alarming was actually the suicidal ideation and suicide attempts. So suicidal ideation was more prevalent amongst cannabis users, and more problematic than that was suicide attempts. So why do you suppose this would be the case? Why would suicide attempts be higher in cannabis users? Any ideas? What about if I were to switch this out and say alcohol is also highly correlative of suicide attempts?
I guess my main thought is like around disinhibition. If it's like someone that kind of struggles with those thoughts, but then is like, oh, I don't really want to do it, but then you have a disinhibiting substance, then you're more likely to actually make an attempt.
Exactly correct. So the number one risk factor for suicide is access to means, right? I have a gun, I have pills, I have a bridge to go to. The number two risk factor is intoxication. So, intoxication on a substance. And this is why it's incredibly important to understand when a patient comes to the emergency room with suicidal thinking who is intoxicated. The very pejorative and terrible term drunkicidal, I'm sure all of you have heard. And it's very true of all substances of abuse, and that is when you're intoxicated, you have disinhibition and the potential for actually attempting and completing suicide. It is the second most important thing to consider aside from owning a firearm or having a stockpile of medications. And cannabis is not unique to that. Um, I think socially and colloquially, people think of cannabis and they think of Cheech and Chong and eating, cheeseburgers and, watching Adventure Time and sitting on the couch pounding Cheetos. And for a lot of people, that is the case. Um, and for those who have severe substance use disorders, who actually develop cannabis use disorders, these are actually not sort of innocent states of intoxication. People can absolutely have um, suicidality associated with intoxication. Okay. All right. Cannabis and PTSD. Anybody heard a patient tell them that they use cannabis for their PTSD? So in Washington State, actually, uh, according to the law, if you have PTSD, it qualifies as a condition for being able to use medical cannabis. And we're going to talk specifically about why that happened and where this information is coming from. So there is a dense expression of CB1 receptors in the amygdala, hippocampal, and cortical striatal areas. And actually, the CB1 agonism acutely can reduce anxiety, it can improve sleep, and it can improve extinction of trauma memories in patients who are using dronabinol and nabilone. So these studies were done in oral cannabis that is not the same as smoking high potency cannabis. But during those initial phases of intoxication, actually people can get better sleep. So cannabis reduces REM sleep and can actually really help extinguish nightmares related to PTSD, which is sort of terrible because I'm about to show you some data that is fairly negative when it comes to outcomes related to PTSD. But when someone says to you, like, I feel better with my PTSD when I use cannabis, what do you suppose is going on? Do you believe them? Does that make sense? Similarly with alcohol. When I drink, I feel better with my PTSD.
I mean, I feel like I'm certainly inclined to believe them and like that experience is very valid. I'm sure because of the memory related effects and the sleep related effects that there probably is some short-term benefit with long-term poor outcomes.
Yeah. So when I am intoxicated, I feel better. No shit, right? I mean, this is a common thing amongst patients who drink alcohol or use cannabis with PTSD. Doesn't tend to be as similar with cocaine or stimulants, because that generally makes people more anxious. And although cannabis can make people anxious, it sometimes also can help with anxiety for people who have anxiety disorders. And so um, and that is in the acute phase, right? When you're intoxicated, I'm not ruminating over my PTSD. And for some people, that's absolutely accurate. But this actually is a study that was done in National VA longitudinal cohort, almost 2,300 patients, and it was done between 1992 and 2011. So this doesn't even account for high potency THC. And these were veterans who were presenting to care with a DSM confirmed diagnosis of PTSD, and they're trying to get treatment for PTSD. And what they did was they looked at 4 different groups: those who had never used cannabis, those who had been using cannabis but stopped during their treatment, those who used throughout and used before, and then those who never were using before and were uh, peer pressured into starting use during the study, and then started using cannabis thereafter. And if you use cannabis, you had greater PTSD symptom severity by the end of the study and throughout. There were more violent behaviors associated with use of cannabis, worse alcohol and drug use in the group as a whole. Stoppers and never users had the lowest PTSD symptom scores, and starters had actually the highest level of violent behavior. So you can very accurately tell someone who has PTSD, specifically in VA populations, but if you're getting treatment or initiating treatment for your PTSD, the likelihood of improvement in your symptoms is much worse if you're using cannabis than if you're not. And this tracks along with all sorts of other studies that show that use of substances when you have PTSD um, worsens long-term outcomes of PTSD. So, um, unfortunately, we don't actually use data to drive laws, and the reason why we actually have cannabis as a treatment for PTSD is lobbying, and not because there's science to actually support smoking cannabis and improving PTSD symptoms. All right, this is a case. Any questions about that? Okay. Somebody want to read this case for me? Mike, will you read this case for me?
Yeah. 36-year-old Iraq and Afghanistan veteran presents to care with suicidal ideation in relation to severe symptoms of PTSD. Smokes cannabis multiple times throughout the day. As he says, it's the only thing I can do in order to leave the house or do anything without freaking out. Patient has been out of the service for 3 years, has never sought treatment for PTSD or substance use. Relates a story, which he relates a story which prompted this admission. Okay. Last week I was at Safeway shopping with my wife. I hate doing it, but I'm trying to get out because she says she can't live with me anymore if I don't start doing normal stuff again. We were in the parking lot and a guy pulled up behind me when I was trying to back out of my space. I honked and he wouldn't move. I saw him reach in his glove box, and before I knew it, I threw it in reverse and ran into him. I pulled him out of the car and started punching him before I recognized he was screaming, "Don't hurt me. I don't want to live like this anymore, and I don't see a way out. What do you want to know? What can we do?"
Has anybody seen PTSD with patients who have dissociative episodes. Psychiatrists, yes. So this is actually an under-recognized thing for very severe PTSD. Is the term flashback is kind of thrown around and misunderstood. A flashback is not a memory. A flashback is actually a patient who is triggered to the degree that they cannot distinguish where they are, what is going on. So, for instance, in this case, this guy was a driver and convoy operator. And so the basic training in a forward military zone is you cannot get boxed in. So if a car comes up behind you, that is hugely problematic because usually that results in uh, 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 a sniper attack or some sort of bomb. And so, so this guy was triggered to the degree of uh, uh, thinking that he was back in Afghanistan. He has no recollection of the specific events, and actually he was arrested for this and saw the video of himself doing this and was like, this seemed like a sort of out of body experience. I don't remember it, and described this because he'd seen the video of himself actually doing this. So uh, we're talking about cannabis. So this is like, guess what I'm thinking. But what do you suppose the story is with this guy, and what would you want to know in relation to his cannabis use and PTSD? So my first question was, were you high when you did this? Right? Because a lot of folks will tell you, I can't leave the house without smoking. Um, he was quite intoxicated at the time of doing this. Um, and it was a huge motivator for him to actually find some other way to cope, because he had never had an episode where he'd been violent before. He'd had plenty of times where he had had dissociative flashbacks, but had not actually acted out violently in that way. Um, and in this situation, what treatments could you actually offer this person if he said to you, "Hey, I want to stop smoking cannabis"? What would you do? Call a psychiatrist. Seriously, though, you'll see these patients frequently in primary care settings. I'm sure you have already.
I mean, I think about like, what are we going to do multimodal? Is
Yeah.
there PTSD related therapy that we can get him in?
Yep.
Certainly, are there medications like prazosin, other type of things that we could add on? Yes, contingency management.
Yes.
I don't know. So I think yeah, I don't think it's just as easy as taking away the marijuana. But I think, yeah, that's how I would approach it, is kind of like multi-pronged and seeing what else I can offer.
Yeah. And just recognizing that people are coping, with the symptoms they have with cannabis, and we do have medications that can help. So, this guy had never been on an SSRI before, so it's very easy, basic to start him on an antidepressant, which helps with anxiety related to PTSD. We started him on gabapentin, and then also prazosin. and as you suggested, the psychotherapy piece. But he ended up doing really, really well on high dose SSRIs and gabapentin, and that sort of allowed him to actually engage in the psychotherapy. Because the other thing you'll find with patients who are using substances to cope with PTSD is they have a very difficult time actually doing exposure-based therapies, which is the gold standard treatment for PTSD. And so they won't be able to tolerate doing it without getting high beforehand, and in which case it actually doesn't have fantastic evidence for extinguishing trauma symptoms long term if you're intoxicated at the time of your interventions. So um, that's actually also one of the critiques of the dronabinol study is, yes, maybe it helps at the moment in time, but the sticking power of it tends to be less robust long term. So cannabidiol on psychosis is very interesting. So the cannabidiol is, as a reminder, antagonist, partial antagonist at the CB1 receptor, and then potential uh, agonism at serotonin receptors. And there have been 8 studies actually looking at specifically CBD in psychosis. And what it has shown is actually 5 out of the 8 trials reduced psychotic symptoms. And these were specific to schizophrenia and people who have Parkinson's disease. There was no improvement in patients who had psychosis related to mania. And what I will say is that it's really important to recognize that cannabis absolutely can be associated with first manic episodes. And again, not necessarily that we know it's causative. There's probably some genetic underpinnings that predispose people to this, but cannabis can absolutely induce uh, psychotic syndromes related to mania. Um, Theoretically, why does this actually happen? There's a thought that the endocannabinoid degradation is actually reduced. So you get competitive inhibition and with anandamide, which is your endogenous cannabinoid. And then the potential of the antagonism of CB1 when activated by THC. Cannabidiol on anxiety. So there is 2 studies also looking at this. By the way, these are studies of infused CBD, so IV CBD. Certainly, this is not something that is available regularly. And actually, it's really hard to find pure CBD in a dispensary. Most of the products that sell are THC rich products. So subjective anxiety and people with social anxiety disorder actually got better. And that's really the main impact that cannabidiol has been shown to support. The limitations obviously is, there's inconsistent doses of these medications, and then also these particular studies had SSRIs and antipsychotics as adjuvant. So you have to take this information with a grain of salt. All right, so let's talk a little bit about medical marijuana and sort of what this means in Washington State, because patients will misunderstand this all the time. So you actually, if you ever see a green sort of cross, like not red cross, but the green cross, those are medical marijuana shops. And most of these places, on the front of the building, there is some sort of licensed practitioner who will recommend cannabis for you. Buying a card is actually not necessary. They will sell you a cannabis card, but what you actually need for medical cannabis in Washington State is just a provider who says, you have a condition that can respond to cannabis. So this actually is not regulated well whatsoever. It's really more about finding a provider who's willing to do this, and these dispensaries literally have them up front, and they will charge a certain fee for the medical appointment. And so why do people actually do this? You can get more cannabis. You can grow your own cannabis if you have a medical approval to use cannabis. These are the diagnoses that are approved for medical marijuana in Washington State. Anybody look at this and see? Let's see here. So there's 4 out of these that actually have evidence, 4 conditions. The rest of them are um, very dubious. Maybe I know what the evidence currently supporting cannabis for a medical condition.
I'm
I think
hesitant to
perhaps,
say this, but maybe seizure.
Yeah, so actually CBD and seizure disorder, so people who have epilepsy, there's some evidence, yep.
like cancer related or like treatment related side effects in cancer, folks with
Yeah,
cancer.
so pain and nausea associated with cancer, wasting associated with HIV, and then glaucoma. Pain literature is actually very dubious because it can work for some patients in some situations for pain, and then some not. But PTSD, renal failure, Crohn's disease, multiple sclerosis, um, spasticity, these are all fairly dubious. But with all of that said, um, the reason I bring this up is just to really show you that these laws are not created by doctors. They're not medically based. They're based on lobbying from uh, the cannabis industry. So the medical marijuana under the new, so I-502 is the new legalization as of 2014. And so the difference is people can grow themselves if they have a medical marijuana approval. And then they can have what is referred to as a 60-day supply, and that's defined as 24 ounces or 15 plants. Does anybody know what 24 ounces of weed looks like? So an ounce of weed is a lot. So you're talking like bricks and bricks, right? Like an ounce of weed highly packed down it is like this kind of amount. So that's a lot of weed. Um, so the law now, you have to actually obtain this from a state licensed retailer if you don't have a medical approval. You can't grow your own cannabis for recreational use. You've got to be 21 years old. 1 ounce of usable marijuana or 16 ounces of infused products or 72 ounces of infused liquid. Anybody see the potential irony in the way that this law is constructed? What do you think the THC content of an ounce of infused product is compared to an ounce of flower? So order of magnitudes higher. So you can have 72 ounces of cannabis that is 97% pure THC. And so some of this stuff was, again, based in non literature or science-based decision making. And the more we see infused products sold, the higher the potency gets. So the laws say that you actually have to have concentration labels. It has to say what the top 5 other cannabinoids are within the product. They actually are supposed to be able to provide a third-party lab that tests for each of these strains. And this is not super tightly regulated. So the variability between one product and the next is fairly high when it comes to flower. It's a lot more consistent with the liquids and the oral formulations of the medication of the substance, but flower can be highly variable in terms of actually how much THC is in each of these things, as you would expect, because it's a plant, right? It's not a tomato doesn't taste the same, even coming from the same tomato plant. One might be a little bit more sweet than the other and have, a different chemical compound. So the one nice thing about this is actually the pesticides and herbicides are regulated. So I had a situation when I was in fellowship where we had a number of patients come into the clinic who had never had psychosis before, who were experiencing like severe psychotic symptoms, and they were all getting the same weed from the same person who was also in the clinic. And after some weeks of kind of talking and figuring things out, the person who was growing the plants was uh, spraying the plants because there were spiders on it with uh, 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 really highly potent hydrocarbons. And so people were actually smoking spider mite killer and got hydrocarbon and organophosphate poisoning. So the idea of actually regulating this is a good thing, and actually helps people who may otherwise get tainted versions of cannabis on the street. Um, so the price of cannabis actually really is highly variable depending on the product and where you go. But the taxes associated with this are pretty amazing. So there's a 37% excise tax that is associated with this, and so what happens is all of the cannabis that's sold, 37% of the final total actually is recouped in revenue. Anybody have an idea about how much 2024, how much revenue did we make in Washington State from cannabis sales? So here's the numbers. So when you combine alcohol, beer, and wine, it's 210 million. Cannabis was almost $500 million. Since the bill passed in 2014, there's been $3.3 billion in revenue associated with taxing cannabis. There's no way this is going anywhere. This is way too lucrative. And interestingly, things like Medicaid in Washington State are supplemented. So 54% of the money goes to Medicaid, 34% goes to the general fund, and then 12% goes to research, education, and treatment. So these are things that like ADAI gets funding, and if you see billboards that are, warnings of cannabis use, commercials, things like that. So the other thing is cannabis is something you can be arrested for driving. And so I'll just show you how smoked THC metabolism kind of works here. And basically what you can see here is in the urine, uh, uh, THC actually should reduce fairly precipitously after about an hour, going down to a nanogram per milliliter. But the law, and I want you to look at 0.5 because that's what the law suggests, and that is or excuse me, 5 nanograms per milliliter. So if you smoke cannabis within an hour of driving and you get pulled over and actually have uh, field sobriety test and the officer says you're appearing impaired, you actually go back to the station to get uh, blood testing. And so, what you really want to look for here is what the plasma levels are. And if you've smoked within an hour, the likelihood is that you're going to be positive. But for patients who smoke on a regular basis, the question is, well, should I be driving or can I drive? And the truth of the matter is, no. Um, so similarly, if somebody's taking opioids for a chronic pain condition, if they're using cannabis for a medical condition, they should not be driving. And what the reason they did 5 nanograms per milliliter is actually they compared it to driving simulations while people have been using alcohol, and that is roughly equivalent to a 0.06, 5 nanograms per milliliter when it comes to just driving performance. And actually, the collision rates have gone up after cannabis legalization, albeit the crashes are at less um, speed with cannabis. Um, and I don't say that just in jest, but like it is something that is interesting about the difference between driving intoxicated in cannabis and driving intoxicated on um, alcohol, and that is that people have similar difficulty driving, but tend to actually just speed less when they're using cannabis. The other thing is that belief systems around intoxication are going the wrong direction. So legalization, social norming, people think that this is something that's actually not going to impair them, and that's worsened as time has gone on, and cannabis is more common. This is a patient resource that I think is really helpful, that you can give to patients. It's updated on a fairly regular basis and just has actual information that's really easy to digest. There's so much misinformation about cannabis out there, and this is a good one. Okay, that's what I've got. I want to see what questions you have about cannabis.
I have a question. Like, I've dealt with several people in the last week that, they have a primary disorder, whether it be alcohol, opioid, whatever use disorder. And then there's marijuana, and there seems to be dependence, but I don't know that they like qualify as a use disorder and isn't something that they specifically are like trying to target or wanting to cut down. So I guess my question is like, how I think it makes sense to be like interested and try to figure out, yeah, what, like you were saying, what they're using, but I don't know, this idea of total abstinence and how that like plays in with marijuana and like recovery from other like substances. I don't know. It's just this complex interplay, and I don't know that I. Sometimes it seems like right now I'm just like kind of brushing it off. Like, yes, I understand, and I want to like um, support you in that ongoing use, but I also feel like sometimes that may not be. It might provide a difficulty in you if getting through some of these other things.
Yeah. And yeah, it's like this sort of global idea of um, if somebody says to you like, I can't stop smoking weed, but I'm gonna stop drinking alcohol, um, and is that okay, right? Same thing with like tobacco smoking, right? Like I can't stop my cigarettes. I'm stopping the heroin, but I can't stop smoking cigarettes. I think there's a very similar sort of philosophy in that, which is if a person wants to stop drinking, hell yeah, that's great. Um, I there's good evidence showing that if a person wants to stop using one substance, that stopping everything at the same time is actually not harder. And so sometimes we think of this, well, I need the cigarette to be able to reduce my alcohol use, and actually that doesn't bore out in the literature. Um, it's actually just the opposite, which is that if you continue using an addictive substance, there is a higher likelihood of developing other substance use disorders. This used to be sort of thought of as like the gateway, sort of idea, and I don't think that cannabis is unique in terms of gateway. Alcohol can be any mind altering substance puts someone at risk for the use of another substance. So it's a slippery slope in that um, if someone wants to stop use and asks you the question, um, should I stop everything, or can I keep using? I would always say, like, if you are wanting to be successful and you do want to stop, you are going to be as likely to be successful stopping everything and more potentially benefited by not using anything. But if you want to keep smoking cannabis and stop using alcohol, yes, by all means, please do that. Um, and recognize that, you know, people often do the sort of swaparoo where it's like increase cannabis use when their alcohol reduces, increase, tobacco use when their amphetamine reduces. And, there is some sense to be had from that, honestly. When you actually look at the negative consequences associated with cannabis use compared to alcohol use, like it's not comparable. Cannabis is not nearly as dangerous as alcohol. There's far more deaths associated with alcohol. In fact, there's far more deaths associated with tobacco than there are cannabis. And that's not to say that it's safe, and especially in the vulnerable populations, the patients I see on inpatient psychiatry. This is not like a totally harmless drug. People can get really, really ill, and people absolutely can have cannabis use disorders. But um, but it but if somebody's going to say, should I stop using meth or stop using cannabis? Should I stop drinking alcohol or stop? If I'm going to use one of the two of these things. Yeah, cannabis is probably the last one I'm worried about. With that said, the other aspect to this is that there's all sorts of things we don't know yet. So, for instance, uh, uh, cannabis smoking um, is not harmless. So people can absolutely get cancer who smoke cannabis on a daily basis. It's really hard to actually separate that from tobacco because there's so often co-occurring tobacco and cannabis use. Um, the new vape formulations actually have all sorts of heavy metals in them that we have no idea what is actually going to be down the road for some of these people who are using on a very regular basis. Putting anything in your lungs that is not oxygen is probably not a wonderful idea unless you have asthma and it's a nebulizer. So there's more to come on it, and I think you're right on, Bill, in sort of thinking about harm reductive approaches if someone is sort of like dead set, no, I'm not going to stop. Other questions? Things I didn't talk about or things that other people have tried or used to help folks that I didn't present here?
For the 36-year-old guy who crashed into someone at Safeway, when you started him on gabapentin, was that just to treat the anxiety, or were you sort of like thinking in anticipation of him like stopping marijuana and then addressing like withdrawal symptoms as well? Is that kind of a management idea there?
Yeah, so it was acute withdrawal, and this actually was a case that it's about 10 years old now, so there wasn't really any data for gabapentin in cannabis. It was kind of an instinctual thing I did with him, and that is, um, I never sort of say if somebody is coming to me and saying like, uh, uh, I want to stop using cannabis and do you have a highly effective medicine? I'm never like, oh, this is the best medication. I will usually try to tell them like this can be useful for people, particularly with insomnia and anxiety, and we want to do that and see if it actually makes you feel better. Um, the uh, the uh, uh, nice thing about gabapentin is just what you're saying, Mike, which is that you can use it in the acute phase for help with withdrawal symptoms, insomnia, anxiety, and actually keep it on in the outpatient and have people have a help with cravings. There's not really great data about gabapentin for cravings associated with cannabis, but it is definitely a safe medication to give people. All right.
I have one question.
Yeah.
Uh, like we have discussed right now that the cannabis or like the cannabis is linked to suicide. That if a patient is having an intoxicated state, then chances of committing a suicidal attempt are high because of disinhibition. But as I've seen like two patients recently in past week, that after quitting the cannabis, like within 1 month period, they both came to hospital with a suicidal attempt. So after the like withdrawal phase, also it's linked to increased suicidality or not?
Yeah, great question. I really appreciate that question. So, this is actually true of lots of substances, which is that the acute phase of withdrawal is very distressing. People are adrenergically charged, they feel unwell, and that is absolutely a higher risk period. So, not just intoxication, but also acute phases of withdrawal can be problematic for people. In fact, um, the tobacco lecture that you'll get in a couple weeks, we'll talk a little bit about this, but varenicline was associated with a black box warning for suicidal ideation. Patients who had a history of suicide attempts or suicidal ideation for a long time were not supposed to get varenicline because it potentially would increase that risk. And the truth is that is not actually the case, and the black box warning has been removed. But when you talk to somebody who is stopping smoking, they're not sleeping well, they're anxious, they feel terrible, and so that absolutely can worsen underlying mental health symptoms. So you're absolutely right in that that is a higher risk period of time, particularly acute and protracted phases. Not as problematic as intoxication, but still there. And why you also want to do what you can to help withdrawal symptoms, i.e., the gabapentin, SSRI, prazosin, etc. All All right. Other questions? Okay. So next